Hello, my name is Kristina Saarepera. I am Minek German in Estonia. I will talk about referring patients for implant therapy. Implants belong to everyday dentistry. The fact that we are able to replace missing teeth without damaging the others is just great. To use implants in one's practice, one does not need to place or even restore implants. It can be referred out with great benefit to everybody. I have worked with implants for almost 20 years now. For the last 3 years, I worked mainly with Megagen implants. I'm a general dentist with master's degree in implantology. In my little presentation, I would like to talk about some things that have crossed my mind when treating referral patients. For more practical input, I would suggest how to prepare and inform the patient before implant therapy and how to effectively transfer information to a specialist. Dental professionals who do not work with implants every day might be insecure whether they have enough knowledge about this topic. Information is quite specific in details that not everybody is familiar with. Like, look at this slide, how many details there are in just a little implant screw. And how this quite horrible looking situation actually turns into that one. Might be difficult to explain why we need to do what we need to do. Might be difficult to understand even for a dentist. Often happens that patient comes to implant consultation with a question, my dentist wanted to know if you can place an implant here. Well, there are many ways to place implants, huge number of systems available, other methods and materials, believe me, mostly we can. But implants are never first-line treatment, except for frontal trauma case perhaps. People lose teeth because of something, an oral disease, be it periodontitis or caries. This cause needs to be under control before an implant can be placed. Our duty is to save people's teeth, not to replace them with titanium. A patient who doesn't care about his teeth will never care about an implant either, and that can lead to problems. Periodontitis is especially important. Previous history of periodontitis raises risk for peri-implant disease even if teeth are removed. Literature is full with evidence to prove this. A tooth with a periodontal pocket is likely to turn into an implant with a pocket, which is PERIIMPLANTITIS. Combination of smoking and periodontitis is bad for implants. Patient needs to know this. Some specialists may even refuse to treat such a patient. However, on smoking alone, evidence is not as straightforward. It depends on number of cigarettes per day and some other factors. So, smoking is not an absolute contraindication, but rather a factor that contributes to problems. Smoking patients should be advised to stop and keep reminding if he does not. Caries and its complications are less dramatic from implants' point of view. Caries patients can even benefit from implants because no decay damages titanium. Still, if neighboring teeth are heavily restored and have periapical lesions, it is better to consider the prognosis before placing an implant. Here is a case of caries-related tooth loss. There may be other options of dealing with this situation, and I'm not happy I could not save her tooth. But the patient's choice was to place an implant here because she already has some well-functioning implants in the mouth. It was an immediate implantation, and after healing we could make a very nice crown. Hopefully this well-shaped implant crown can last long. Often teeth next to implants need treatment as well. First, implants were placed and immediately loaded. During restorative phase, neighboring teeth were fixed with fillings and a crown. This gives better prognosis to whole quadrant. At last, teeth next to implant should be well restored. Bad fillings close to implant can contribute to bone loss because of food trap and difficulties in keeping proper hygiene. Last but not least, we shouldn't let patients to lose teeth, so let's treat them before they need to be taken out and replaced. If we have non-restorable teeth next to implants, how to handle this situation? In this case, patient lost tooth 1/6, which was replaced by an implant. When old crowns were removed from neighboring teeth, it revealed that the prognosis for them was poor. If teeth next door are not restorable, it may be better to remove them and plan for more implants right away. First, the outcome of implant treatment is better when implants can be properly placed and augmentation procedure is successful when bone and soft tissue are healthy. Secondly, it is much more convenient for patient to have one surgery and place necessary implants at once. Thirdly, we may save a number of implants and thereof the cost of overall treatment. In this case, second implant was planned on location of missing canine. Hoopless premolars were removed to allow better implant positioning. Immediate loading was performed to provide patient with teeth in aesthetic zone. This is one of the important aspects about keeping suspicious teeth. Nobody wants to walk out without teeth, and it will be a very difficult task to replace and immediately load a single implant that is replacing a bad tooth that is between non-removable restorations that have been recently done. After healing, we can see nice situation with base abutments and make a nice 3-unit screw-retained bridge on 2 implants with very good long-term prognosis. Here are some points to consider why it is important to prepare and educate the patient. Making patient aware of his situation and how he can contribute to solutions is the best way to get into cooperative relations with him. On consultations, patients often ask if implants stay for the rest of their life. Well, it depends how long their life is. But seriously, if teeth were lost, how on earth can implants do better? God didn't create implants. Patients need to be informed about how their choices and habits influence the prognosis, that implants are for patients' benefit, not dentists. If we plan and act well, this is achievable. Implant is quite often the best way to restore dentition, but we can't promise something that is out of our control for the most of the time. So, patient is well prepared and ready for implant consultation. Almost certainly an implant can be placed anywhere it's needed. The question is rather, do we choose to use an implant? What needs to be done for implant placement? What risks are involved? Are they justified? Is patient willing to accept these risks? To consider all of this is called a therapy plan. For reliable implant therapy plan, some essential information is needed, such as radiological data and occlusal analysis. Actually, no implant should be placed without considering these variables. It may be perfect place for implant fixture, but there is no place for crowns. Patients do not want implants, they want teeth. This patient needs very comprehensive treatment before he can get teeth in this gap. It's not smart to start with placing implants. Implants placed without guidance can end up not exactly as planned and in worst case even damage teeth. No referring dentist is happy to make a crown on this implant. Well, somebody still had to, and look what came out. Everything came out. Luckily, we have some smart software solutions today that help to avoid such mistakes. Artugate is a nice tool which allows implants to be placed very precisely by plan. It's an open platform that can be used with a number of implant systems, also from other companies. Look at the precision of the planning and execution, or execution and planning in this case. To be able to use this system, there is a protocol for data collection. I share with you digital protocol, but of course it can be done with analog approach as well. Info about dentition can be transferred in form of diagnostic models or intraoral scans. I mostly work with scans nowadays because they are more versatile and patient cannot forget them on kitchen table when he comes to me. If indicated, occlusal adjustments can also be planned on these scans and temporary restorations designed and fabricated along with a guide. Radiological data collecting needs to be appropriately carried out. Just a CBCT is not enough in most cases. If guided surgery is a goal, then a CBCT needs to be taken with orientation tray. For R2gate, it's called R2 tray. Tray needs to be stabilized in mouth with silicone while taking X-ray and needs to be visible on CBCT. If plaster models are used for planning, this tray needs to be sent to R2 center together with the models or impressions. In R2 center, match is made with scans and X-rays. It is possible to make merge also in office, so anybody who wishes can do it himself. However, it is reliably and quickly done in R2 center and clinicians' time can be spared. Plus, somebody who does it many times a day is much faster and more precise, and this is what digital planning is all about. Implant position is planned and the implant specialist verifies and confirms it. Now, if everything else can be done also by a referring dentist, this step, confirming the implant position, needs to be done by specialist. After confirming, the implant guide is manufactured and ready to use. What's important if referring dentist makes planning? In case patient has temporary restoration of any kind, that needs to come off for implant placement. All models or scans need to be done without the temporary. Also, CBCT orientation tool needs to sit on teeth, not on temporary. Guide is very precise, and if it doesn't fit perfectly, there is no point in using one. Any kind of restorative procedures that is in region where guide needs to sit on teeth should be postponed until implants have been placed. In more complicated cases, face scan can be added for diagnostic purposes. Here is a case of full upper implant bridge planning with help of face scan. Pre-op dental scan or model file is merged with CBCT data with help of orientation tray. Patient's face scan is taken. An orientation tool is also used for this. Face scan is now merged with CBCT data for bone structures, intraoral scans for teeth, and the design file for future restoration, which is a base for implant guide. Implant guide and temporary bridge are fabricated. Thanks to face scan, we know already how it will look when it's fixed on top of the implants. Temporary bridge and implant stent are fabricated, implants placed by plan and immediately loaded. Prosthetic phase is crucial for good long-term prognosis. There is a sea of choices in prosthetic field: cement or screw, individual or custom abutment, zirconium or lithium disilicate, to connect or keep separate, and so on. What to choose depends on clinicians' choices, but patients' individual risks should also be evaluated. For example, a perio patient should rather get screw-retained single zirconium crowns because they're easier to clean, material has low bacterial adherence, and there is no cement that can be difficult to remove. A proxing patient, possibly, should get connected crowns in highly loaded areas such as molars because it reduces technical failures. Here is an example of connected molar crowns and example of screw-retained crown. There are prosthetic protocols that enhance good implant prognosis and soft tissue contour, like one abutment one time, individual healing abutments, scan healing abutments, or immediate loading with temporary crown. If one understands and utilizes these techniques, It's easy to get nice results with small effort. One abutment one time means that final abutment is inserted at the time of surgery and never again removed. This case shows use of octa abutment, a base abutment that can be temporized if chosen. At the time of surgery, and later impression for permanent construction is taken on abutment level. Scan healing abutment is almost one abutment one time because it can be inserted at the time of surgery or implant uncovering. During prosthetic phase, on top of the healing abutment, a scan body is mounted, and healing abutment itself is removed only when permanent crown is ready and can be inserted. Very convenient and great for prognosis as well. In case of frontal implant, when immediate loading is carried out, patient comes back to referring dentist with temporary crown. The subgingival part of the crown should be precisely copied because as the crown is inserted at day 0, all tissues around it have been shaped by this form. If pressure is applied to sensitive areas like buccally or proximally, there might be loss of papillas or change in gingival contour. Also, the crown should be taken off as few times as possible. Digital protocol helps here as well. First, initial situation is recorded, then temporary is removed and quickly gingiva is scanned for emergence profile. Scan body is inserted, its position verified with X-ray and scanned. Temporary crown is scanned outside of mouth for subgingival shape transferring. All this can also be done with analog impressions, of course. Then temporary crown's subgingival portion should be copied for impression post-individualization. As impression copings and scan bodies should always be verified for their seating with X-ray, this same X-ray can be sent to lab to help in designing emergence contour. Mark the bone, technicians are not always as good as dentists in reading X-rays. In this way, a situation when crown is too close to the bone can be avoided most probably. A 3D image can be used if one is available after implant insertion for planning purposes. When using model-free workflow, all these additional measures help lab to make well-fitting restorations and minimize mistakes. In this case, a scan for restorations was done at the time of implant placement on scan healing abutments, and final crowns will be ready when patient comes back after healing period. When restoration is ready and back from the lab, all components that go subgingivally must be cleaned very thoroughly. Contamination of sulcus with particles that are on abutment surface can lead to peri-implant problems. Also, if healing abutments are used, they need to be cleaned so no foreign material is transmitted. For cleaning components, different methods can be used. Steam is a good method. It's used in most labs. Cleaning can be done chemically using different agents such as hydrogen peroxide or alcohol. Ultrasonic bath is very good. For example, Med Cleaner is such a device. Maintenance is crucial for long-term prognosis. Regular follow-up visits with patient's own dentist are easiest way to do it sustainably. During first year, implant patients should be followed more frequently to make sure he's coping well with hygiene measures. Perio patients with implants require closer observation. Radiologic follow-up is indicated at regular interval or at specific need. It's always a good idea to share follow-up X-rays and photographs should they have been taken with implant specialists as well. With that, I thank you for listening and hopefully something from my presentation was useful. I thank my good colleagues for referrals and my smart lab and Artus Center in Tallinn. I thank Megagen for the opportunity and trust to be able to share my way of working with the world. Be healthy and be safe.